All right then. Okay, what I'm going to talk about is about the glaucoma drainage device and how important it is in of its hypertensive phase. Because I know that this is my financial disclosure. I have no any conflict of interest of any products. Well, the surgical intervention in glaucoma, there are many, and we talk about the mix or microinvasive glaucoma surgery. But I think the glaucoma drainage device is still important for cases that advanced and perhaps need a very low target IOP. But anyway, the indication of the glaucoma drainage device in the Asia Pacific glaucoma guidelines happen just like this. So we can conclude that if any surgery, any glaucoma that can be, easily failed by the trabeculectomy or has been previously failed trabeculectomies or has a conjunctival scarring because of the prior multiple ocular surgery or any from any cause, or perhaps in the case just like a eye syndrome or neovascular glaucoma. This is one of the indications for the glaucoma drainage device. We have, yes, we all know, we have got valve, we got non-valve GDD, and the AMED and the barbell is something that been preferred for many years, but I think we might have heard about something else, just like a Susanna or the Paul glaucoma drainage device. Both of them are non-valve types. Anyway, we talk a lot about the post-drainage device, post-DDD implantation. What happens? Post-operative intraocular pressure usually undergoes through three phases: the hypertensive phase over the first week, and then run into the hypertensive phase and the steady phase after that. The hypertensive phase usually occurs between 2 weeks and 3 months, but how important it is. I think this phase has been mentioned a lot, particularly for the AMED or the valve GDD. So what is going on inside? What importance of the hypertensive phase? We have to remind ourselves that the most patients who receive GDD had advanced glaucoma. So when hypertensive phase happens, it could further damage the vulnerable optic nerve because the IP can be as high as 50 millimeter mercuries, and the average time for the hypertensive phase to occur was about 5 weeks, both in cases that documented successful GDD or the failed GDD. The average time, it seems not to be much different. How's about the incidence of the HP or the hypertensive phase? It's different. It depends on the definition of each study. In some study, barbell can happen about 30%. AMED can happen about 40 to 80%. In some cases, as you can see from senior or all, in barbell, you could not see any hypertensive phase, which is 0%. So is it possible? Anyway, what happens during those times with the black walls? The study from Korea says that this is from the ACOCT, and you can see here this is this is day 1, month 1, 3 months, and 6 months after surgery. You can see the black wall has changed over time, and statistically significant difference between hypertensive and the non-hypertensive phase in terms of the thickness and the reflectivity. The material does it any effect on the HP? The comparison of the polypropylene and the FP7 model, which is a silicone AMED, this may suggest that the plate material may influence the clinical outcome. And the double plate modular has lesser HP than the single plate. If you can see that. Anyway, the modular is polypropylene anyway. So come to our mind, what are those risk factors of the hypertensive phase, and does it lead to surgical failure? This is what we're gonna always in doubt. The risk factor has been studied for quite some in some study. The high incident mainly in AMED implant, and has about the barbell implant. So this usually the AMED implant has been studied over its risk factors. In many studies from Korea, which is mainly done on AMED, the hypertensive phase was found in the long axillary group because they found that the hypertensive phase was higher in the high myopic rather than in the non-high myopic. Moreover, they will say that if they compare between the success rate between HP and the non-HP, you can see that there is no the significant difference in the surgical success. And the long exit length of this study was considered just only the factors that leads to the hypertensive phase. In another studies, they study in the silicone amide glaucoma device, and they found that about 30% of them experience the hypertensive phase. The significant risk factor is the preoperative IOP. The higher the IOP is, the higher of the hypertensive that they will develop. The qualified success rate was not significantly different between the HP and the non-HP. However, in the non-HP group, the complete success rate was significantly higher. Moreover, the medication was lower in the non-HP group in comparison with the HP group. So the risk factor from these studies seem to be that depends on the long exit length, depends on the pre-op IOP. However, the success rate was not statistically significant between HP and non-HP. But anyway, in non-HP, they found that the lower medication is needed. So how's about the HP after the other GDD? Those was studied in AMED. In our study, we look at the bowel implantation. This is from Chulalongkorn, which is in Bangkok, in my study and my colleagues. We evaluate the rate of the HP anyway, because the number is rather not that high, but just only 37 eyes with the bowel. And you can see the rate of the HP in this bowel group is as high as nearly 50% at onset, just like that. Just like 2 weeks to 3 months. The definition from bowel, which is a non-WAP, is different from the AMED anyway, but we found the same thing. We found the same occurrence. The hypertensive phase and was not associated with the surgical failure in our studies. It's similar to the other study that the success rate not different between the HP and the non-HP. So we look at the surgical failure. HP was not associated. However, the HP can predict the need for long-term anti-glaucoma medication, because the same thing that we found that the anti-glaucoma medication was higher in the HP rather than the non-HP group. Another thing that we do with the factors related to hypertensive phase after glaucoma drainage device, we look into our the overall of the GDD that we use. This is the criteria or the definition of the hypertensive phase and the failure of treatment. And the baseline characteristic, we say that we use about more than 50%. The overall outcome after 12 months post-op is just like, the IOP is quite satisfactory, because from 27 to 13, and the number of medications has been less and less. In each individual glaucoma drainage device, 50% has 50% of MAMET has HP, Barbell 55%, Martinez 40%. So actually, it was high in all of those GDD that we found, and mostly between 2 weeks and 2 months. The factors related is quite different, because the heart disease we found that is related. Pre-op IOP is VA. The better VA is related to the HP group, but not with the type of the GDD. Why is a pre-op VA? Because we think that the design might have the GDD implantation due to aggressiveness of the refractory to control the conditions rather than the severity of the optic nerve head. That's why it does not affect the VA, the patients. And the protective factors, why presence of the underlying heart disease is the protective factor in our study. We thought that because all those patients, they took either dual antiplatelet or the aspirin, so might be they have received the anti-inflammatory action of the aspirin that prevent all the scarring during those hypertensive phase. The type of the GDD and the pre-op IOP was not found as a risk factor in our study. However, the mean survival curve between an HP and an HP group is not different. So the take-home message is that high importance is the hypertensive phase. GDD is the effective surgical procedure, and the IOP medication can be less. Hypertensive phase commonly occurred either in any individual GDD you have to, whether it is valve or non-valve. The incidence varies. It depends on the definition. However, the rate in our population was about 50%, so half. The associated factors might vary as well. Pre-op-IOP, the axillary, probable or concurrent anti-inflammatory use might be the protective one, but no association between the surgical HP and the surgical failure. So high peak and HP could further damage vulnerable effects. So these patients that had GDD requiring close follow-up. That's it, and this acknowledgement to my colleagues, and thank you so much. This is a view from the park and into the buildings of our institute over here in Bangkok. Thank you so much.